Good morning, students. We are going to start our lecture on parenteral medications. These are injectable medications that are injected through the skin using a needle. Could be that the patient already has a port in, but parenteral medications go in through the skin. That includes then injections of subcutaneous nature, intradermal, and intravenous and intramuscular. So onward we go. Medications administered by the parenteral route enter body tissues and the circulatory system by injection, as I said. What are the four routes of parenteral administration? I'm going to give you a minute to think about it, or a second to think about it. You should, if you're just now listening to this PowerPoint, you may not know them yet, and they are subcutaneous. That goes into the tissues below the skin. The next one is intramuscular. That goes into the muscle of the body. Intradermal goes just under the epidermis and the dermis. And intravenous goes into a vein. Those are the four types of parenteral medications. Injected medications are more quickly absorbed than by mucous membranes or oral or topical routes. And when a patient is vomiting, can't swallow, or is restricted from taking oral fluids, these are the preferred method, perhaps, of taking medications. Injections are invasive, so we have to use aseptic technique, of course, and we will teach you the best aseptic technique that we can in the lab. Okay, when we are doing intradermal medications, of course, this is a dependent action, right? We have to have an order for this, and we will clearly, of course, talk to the interprofessional team. Technology would be using the EMR, and a lot of patients will have to be taught how to do these at home. Specifically, you can think of insulin, of course. Patients will be giving at home. They'll need education about their medications and how to minimize their own discomfort or the discomfort of their family member that they may perhaps be helping. A couple of the rules to minimize discomfort here would be to use a sharp needle. There's a bevel on a needle, and I will show you that. Use it for the shortest amount of time. Use the shortest length and the smallest gauge possible. Those will help with pain. Also, make sure that the patient is relaxed. They're not in a flexed position, as specifically when you're going to put into a muscle. And make sure that if the patient is younger, you either do some distraction or you use a cream that will help to numb the skin or decrease the pain upon injection. Okay, the next slide, of course, is about patient-centered care. We understand that patient-centered care would be specific to that patient, perhaps culturally, perhaps genetically, perhaps, of course, cognitively and behaviorally. These things need to be taken into consideration. When you guys are in next semester, you'll talk a lot about, medications, injections, specifically into pediatric population. You should have a knowledge about the variations, especially what is the difference between absorption for a sub-Q or as an intramuscular and adverse effects that may happen. It is different for those who have skin of very dark color for us to see perhaps a raised reddened area. So you'll have to make sure that you're teaching correctly to that population of people, especially signs and symptoms to report after an injection. Selecting needle size is based on gender, at times weight for sure, body mass index, condition of the muscle or the site, and the volume, of course, that you're going to give. So we want to, for example, reach the muscle when we have an intramuscular injection. We don't want to use too short of a needle that will end up having the medication being absorbed in the subcutaneous space. So we will need to make sure, especially on intramuscular, we're using the smallest gauge, but the correct length to reach the deep muscle of a patient, perhaps who has a lot of adipose tissue or has very little muscle structure. Some medications go deep IM. I want you to write down Z-track, Z-TRACK. That is a type of deep intramuscular injection that we'll talk about at about week 12, 11 and 12, and we will want to make sure that you understand that. For now, I want to make sure that you understand that, of course, a patient can have a localized reaction. Localized means in the local area where you gave the shot, perhaps some redness, maybe a little heat, and some soreness with maybe a slight fever is an expected response. That's not an allergy, but we certainly don't want to cause numbness or nerve injury or muscle injury or tissue injury. Okay? Make sure you assess the skin. Also, for our little older folks that have poor skin turgor, we really like to make the skin tight or put some tension or retraction on the tissue so that the tissue doesn't move around when we're putting the needle into their body. Most intramuscular injections are at 90 degrees. We will give an insulin injection at 45 to 90 degrees. And before we're done with this lecture, I want you to make sure you understand the angle of insertion for each type of a medication injection. Okay? And then when we're doing intramuscular, again, we'll talk about later, we do wait a few seconds. Your book says 5 to 10 seconds before withdrawing the needle to make sure that all of the medication has gotten out of the needle and by gravity perhaps dripped or dispensed into the muscle before you're taking it out. So what I'm saying is we don't just inject, go in and out that quickly. You need to wait a second to make sure the medication is gotten through the needle, the very end of the needle, before you withdraw the needle. That's an important concept when we're giving medications by injection. Avoid distractions, of course. Making mistakes, of course, is not something we want to do when we're using a vial, perhaps even a multi-dose vial. Insulin, for example, is a multi-dose vial. There's many doses within one bottle. We want to make sure it's not expired. And the rule of thumb is 28 days on a multi-dose vial. You must write the date and time on a multi-dose vial the day that you open it so that everyone knows when that medicine has expired. If it's a multi-dose, think about this. It's being injected into and a needle injected into the stopper many times. We don't want the preservative that's in that fluid to wear out and to have the medication become tainted or toxic in any way. So 28 days is the rule on a multi-dose vial, making sure that you date and time that. Also making sure it hasn't expired before let's say that it's going to expire at the end of July and it's July 10th. You won't have 28 days on that vial. So just be very careful to check that. 2 identifiers, of course, are used and allergies before you inject into the patient. So we're going to make absolutely sure that we've asked those questions before we are going to give the medication by injection. Next slide. Any unclear orders, ask about those. In your validation, if something is unclear, we want you to ask us. Follow the policies for workarounds. We don't use workarounds, meaning, I'll take it out now and put it in my drawer and give it later. And asepsis in the lab is extremely important when you're using injectable parenteral medications. Think about your own family member. If the nurse was not using aseptic technique and cleaning the vial and was laying the needle perhaps onto the surface of the table, you would not want that injected into your child, nor would you want that injected into yourself or a parent. So you will learn correct aseptic technique so that when we're giving the injection, we protect our patient at all costs from any kind of infection that might occur because of our injection policy or our injection procedure. Most of the time you can't delegate this. MAs can give medications at times. We've talked about no interruption zones. Very important to know the proper angle and needle size and a smooth dart-like motion for the injection of a medication, especially into a muscle or in subcutaneous space, so that it's not something that takes a very long time. When I'm teaching you, I will teach you just a slow, smooth injection of the stopper. We don't go fast, we don't go too slow. We just steadily inject the medication in a steady fashion, and we will learn that in the lab. Again, really important that the syringe is held steady. If you have a needle in someone's leg and you're moving that syringe around, it's very painful, okay? We withdraw it as smoothly as we inserted it. We gently apply an alcohol swab or dry sterile gauze, and we don't push or massage. We just apply it with pressure over the site so that no medication leaks up toward the surface and so that the medication can stay where it's been put. A little gentle pressure is always put at the injection site, and very important for insulin. Rotating injection sites, we will have people who will get lipodystrophy, lipo meaning fat, dystrophy meaning abnormally shaped, like divots in their skin and their subcutaneous tissue. And of course, when we're not using aseptic technique or using the same site over and over again, someone could get an abscess. So we are always very careful to rotate. We will teach you this on insulin, and I believe it's coming up here on a slide, but rotating to make sure when a person takes 4 insulin shots a day or even 2, they cannot be given in the same space. They need to be rotated daily to make sure that they are not getting, dystrophic type of tissue that might be, really scar-like, that is hard, and then it doesn't absorb medication. Hold the syringe steady once it's in, as I said. Withdraw it smoothly. Oh, we did that slide. Excuse me. Moving forward. Okay. I will teach you very specific sharp disposal. Now, if you remember back, we talked about this in week 1. Disposing a sharp is a one-handed technique. As you see here somewhat in the picture here, it's a one-handed technique to cover the sharp with the engineered protector, and it's also a one-handed technique to put it in the sharps container. Never do I want to see you jamming open the sharps container because it's full and trying to put a needle in there. That is not the correct procedure of asepsis for putting a needle into a sharps container. It's one-handed. It should be very easy to do and not in any way forcing the needle into the sharps container. Okay, we'll do that in the lab as well. This is a one-handed picture, as you can see here. This nurse is putting the needle in with one hand. The second hand is not holding onto the sharps container. And we usually will use a very standard biohazard equipment storage for the needles. Here is a syringe. We're going to be learning about the barrel of the syringe. The tip is normally called a Luer lock. Luer lock, as you see here where my cursor is. That means the needle sort of screws in with a tongue and groove sort of action, and it'll stay on more securely. The plunger is this here that I'm showing you, and we'll teach you how to measure. You'll be measuring here at this part of the plunger that meets or touches the sides of the syringe. You'll see that the rest of this plunger doesn't touch the sides of the syringe, so the only visible place where you'll see it touch is where you're measuring. There's a couple examples here of some insulin syringes and some TB syringes and some larger syringes. There's many sizes, many colors. In different parts of the country, and different manufacturers use different colors for their syringes. And once you get very used to the policy where you work, you'll know that an orange is an insulin, or a green is a filter. Just depends on where they buy their equipment. Needles can be attached separately, as you're kind of seeing here, or they can come as one part. Insulin needles very often come as part of the syringe. It's one piece, no needles to dispose of, no extra parts and pieces. So the syringe is the same part of the needle. It's all attached, and then there are others that have 2 and 3 parts. So we'll learn all of those parts in the lab and how to use them correctly. This is called a carp eject, and we'll learn this as well in the lab. It's for a pre-filled syringe. If you see this nurse here, they're using a syringe that's labeled with the medication. It's already filled. I'm not filling it as I use it. And we will learn this in the lab and how to dispose correctly of this and how to use it correctly as a means of injecting a pre-filled syringe. Okay, the first week or two, we will be learning about ampules and vials, as well as PPD, tuberculosis testing. So we'll learn about all these different types of receptacles where we might be aspirating medication out of. The bottom one here is a vial. The top ones are ampules. They are glass. I will teach you in lab exactly how to aseptically use those ampules, and that will be a checkoff that you'll need to follow through on in the lab. This is not delegated to assistive personnel because it usually requires, of course, an assessment by the nurse, meaning which muscle shall I give it in? Does the patient have a site that we are rotating? Has the patient had a right hip, which means I shouldn't use the right side? Those kind of things are involving the nurse assessment. So we will start in week 1 with PPD, which is the tuberculin test for tuberculosis, and we will, after that, start on sub-Q insulin and heparin. So this slide specifically talks about mixing medications in one syringe. If you actually look in your book in chapter 22 in Perry and Potter, Clinical Skills and Techniques, there's a huge, I think it's 32 or 34 steps that you need to mix insulin. It seems daunting in the beginning, but as I teach it to you, it will become less daunting and more intuitive. But there are steps to mixing medications in one syringe. We don't want to contaminate one vial as opposed to the other, and we want to make sure they're compatible. This is something we'll spend a lot of time on, skill on, you'll validate on, and it's hard to explain in a PowerPoint because I will want to make sure that I am showing it to you and demonstrating it for you for you to understand it correctly. Okay, mixing medications is not something that we delegate. However, your assistive personnel should always be able to come tell you if the patient, of course, is not tolerating a medicine. Okay, here's what we're going to start with in the lab, and that is tuberculin testing, also called a Mantoux skin test, also called a PPD. They're all the same. Okay, what I want you to listen to carefully is that these are always done in the same way. Okay, we use a tuberculin 1 ml syringe, okay, with a short 3/8 to 5/8 inch needle, very fine gauge, very thin needle, 25 to 27 gauge. We insert at 5 to 15 degrees. This is important information. TB syringe, angle of insertion 5 to 15. And intradermally, we always will stay beneath 0.1 mil intradermally. Most medications intradermally are given in tuberculosis, especially in adult population, is given at 0.1 mils. There's no milligrams, there's no dosage. The order will read, perform PPD testing upon admission. It won't say how many mils or milligrams. It's not a mil or milligram order. It's a procedure order that nurses are autonomous on, making sure I have the PPD. It's always in adult 0.1 mil. Intradermally, 5 to 15 degree angle with a very small short needle, 5/8 inch and 5 to 15 degrees, as I said, for the angle of insertion. Okay, this cannot be delegated. Perhaps your NAP might come to you and say, the area where you gave that TB test is, itching, or the patient complains of pain, and that they might help you in that way. But otherwise, it's a nursing intervention. Okay, documenting as soon as you've done it. We've talked about this before. One of the 9 rights is documentation immediately after, not before. Make sure on a PPD test, this is going to be test material. It is of importance that you note which forearm you injected it in. for the next nurse. So the next nurse can read it and interpret it using the right anatomy for where it was injected. So make sure that you, for example, may say PPD performed right lower forearm inner aspect, and you might say wheel noted, patient tolerated without complaints, and that would just mean that we have gotten the TB injection finished and that we will be able to see where it is when we come back to assess it. Okay. Undesirable effects from any medication should be documented. Now, this is also a very important point. On any time a patient gets a first dose, let's say, for example, they are getting their first dose of penicillin or a cephalosporin, we want to make sure that we have them in our view for the first 15 to 30 minutes. That means I'm watching for anaphylaxis. Anaphylaxis is an allergic reaction that could be life-threatening, meaning that they do have a severe allergic reaction to the medicine, and it will proclaim itself as, shortness of breath, tongue swelling, wheezing, airway obstruction. So we always watch those patients for 15 to 30 minutes on first injection. Now, if they're coming to your clinic every single week for a steroid injection and they've been getting them for 3 years, or let's say a testosterone shot, then we don't have to have them in our sites for 30 minutes. But on the first dose of anything, IV, IM, or sub-Q, we need to make sure that we are watching them. That means they're in your sites, okay? We tell them not to squeeze on the site. Don't, especially with the PPD, don't scratch it. Don't wash off the markings. Observe, don't change it in any way for a PPD. That's the TB test you guys have all had before. And we don't want them to, be squeezing on it or itching it or scratching it. Okay? For a geriatric patient, as I said before, the skin needs to be taut so that the pore turgor can be compensated for. And when I touch them with a needle, their skin doesn't retract up and away from my needle, which might cause more pain for that patient. Here are the subcutaneous injection sites. Again, important information that you'll need to know. Also, as a nurse, I need to know where are the available sites for me to give a sub-Q injection. This could be heparin, insulin, or anything else that's ordered sub-Q. You can see here that some of the sites are not normal sites, subscapular, and kind of that love handle area around the middle, front and back, and then the upper aspects of the inner thighs are sub-Q, acceptable sub-Q spots. So making sure, and then you'll see here on the tricep area on the back of the arm. So side and back of the arm. So those are the sites, subscapular, tricep deltoid area, upper aspect of the thighs, and abdomen. Okay, peri-umbilical. Peri means around. Umbilical means around the umbilicus or around the belly button is the preferred site for sub-Q. Those 4 sites. Okay. When we use a pen, you guys will do this in lab as well, we will do it subcutaneously. It's usually at a 90-degree angle, and there's usually a standardized needle that fits on those pens that is the correct size for a subcutaneous injection. Okay? Make sure, as I've said here, that you're rotating sites to decrease the hypertrophy or the lipodystrophy that can have happened. Also, it affects absorption, especially of insulin if you're using the same site over and over and over again. The most quickly absorbed site for insulin and heparin is the abdomen. Most slowly in the thighs because most of us have some muscle in our thighs. So when we are looking for quick absorption, oftentimes we use the abdomen. And for insulin, oftentimes that bicep tricep area on the back of the arm where patients have, a fatty area that is present. Okay, moving on. Heparin, as I said a little bit, is you guys have learned from Professor Robinson as it relates to blood clotting. So that means it is an anticoagulant, gives the patient a higher risk for bleeding. Preferred site for heparin is always periumbilical. The manufacturer will ask for you to use that site for the best absorption and the most controlled absorption. Okay. And we would always, of course, be very careful to watch our patients for bleeding because we're giving them something that makes their blood clot less effectively. It can also be given intravenously, however, not by an LPN as a push. And we use something very frequently called Lovenox, Lovenox. That is a brand name of a type of heparin that we use very frequently in the long-term care setting and in the hospital acute care setting and even in the clinic setting. Perhaps for a DVT or a thrombus, that's happened in the leg, we use it quite frequently. This is not delegated to our nurse assistant personnel, but as I said, they can certainly come to me and say the injection site is, the patient is complaining about it. Documentation happens afterwards, as we said. Make sure that you're teaching and taking credit for all that teaching that you do for the patient. I feel like patients who are on insulin and heparin and even warfarin should have an ID bracelet that tells us to be very careful. I was an ER nurse for many years, and I would have been very happy to know sometimes that a patient who had a concussion or who had a head injury, that they had either an allergy or a reaction or they were on a blood thinner. That would really alert me to the fact that they could have bleeding, especially into the brain or, around the trauma site. So I really teach my patients about making sure that they use a medical alert bracelet if it's appropriate. And then, of course, any adverse effects have to be owned up to and put in the patient's chart, teaching them signs and symptoms to report. That would mean if I give someone an antibiotic shot and they're going to go home, I don't need them to call me if it aches slightly or if it hurts a little bit or if it gets a little red or warm, okay? That's not an unexpected side effect, okay? So, but I do need them to call me if they have trouble breathing, if it gets, very large, it's hard, it gets pus or an abscess or fever, right? So I'm making sure you're teaching them what to report back for sure. For geriatric patients, they don't sometimes have very much muscle, so you have to be very careful when choosing your site, especially if it's an intramuscular shot, because that will really sometimes be hard to find the muscular area. Now, we're really moving on now to intramuscular injections, and this is the unit that's coming up after subcutaneous. My recommendation to you is that you stop here at about 27 minutes and come back when we start to do intramuscular injections, but I will continue on and you can certainly review it in whichever way you see fit. An intramuscular injection goes just as it says into the muscle. This requires a longer needle and sometimes a larger gauge, meaning the medication is sometimes viscous or thick. We have a few sites that we will accept as intramuscular sites. These are not the same as the subcutaneous sites. So we have 4 areas, and they are the ventrogluteal, the vastus lateralis, the deltoid, and the fourth and most undesirable is the gluteus. Okay, we don't use the gluteus maximus anymore. You guys will be taught to use the ventrogluteal as the preferred site, and then perhaps the vastus lateralis, which is on the lateral side of the thigh, and the deltoid, which is in the arm. I will be teaching you all the landmarks. You must know these for testing. It's vital that you can pronounce, spell, and recognize these sites for how you would give an injection. This is, in this picture, a sample of a Z track, Z-track. That, as you see here, the nurse is swiping the tissue and muscle to the side, injecting into the layer of muscle, as you can note here, injecting the medicine. As soon as the needle is out, releasing the skin back, and you can see now that the medication has been trapped underneath the fat layer and the skin layer, and it doesn't track to the skin. We don't like medicines like iron and B12 to track back to the skin. We want them to stay deep in the muscle. So this is called a Z-track, and you will need to be able to perform this in lab and show your skill at performing that. This is the ventrogluteal site. Also, you guys need to know the landmarks that you choose to make sure you're giving it in the right site. As you see here in this picture, it's quite high on the hip area, and I will teach you the landmarks in lab, but you will need to know them by name. Not just the word ventrogluteal, but you will have to understand you're looking at the anterior superior iliac spine, the head of the trochanter. And I'll teach you that in class, but you will need to be able, again, as I said, to recognize those. Very important point here, the deltoid can only take up to 2 mils. Write that down, deltoid 2 mils. Subcutaneous space, 2 mils, no more than that. If you have more than that, you cannot use one site, you'll have to use 2. If you have more than 2 mils for an intramuscular injection, you'll have to choose another site. You cannot choose the deltoid. The deltoid can only safely hold 2 mils. Okay? The ventrogluteal can hold more than that. The vastus lateralis can hold more than that, but the deltoid cannot. Okay? So we will choose the site, as I mentioned earlier, based on the viscosity, the patient, their size, their weight, and then perhaps, how much medicine I have in volume. Okay, the second site is the vastus lateralis, side of the leg here, goes in at a 90-degree angle, preferred for infants for immunizations. They have lots of little muscle there. And we are really watching for the femur in this case. I will show you the landmarks as well that we use in the lab to make sure that you are in the right part of the muscle on the lateral aspect of the vastus muscle so that we have better absorption when we're giving the medication. Next one is the deltoid. Again, lots of landmarks here. Acromion process, scapula, humerus are names you'll need to know. And we only give small volumes of 2 mils or less into the deltoid. This is an easily accessible place, especially for adults, to give a medication. Not as easy with kids to hold them still on their deltoid as much as it is on their vastus. But you'll have to know the landmarks here, and you can choose the site. Oftentimes the patients will say where they prefer, and we'll give the medication where they prefer if we're able to put that volume in the muscle. Okay? Again, not something we delegate. They can sure come to me and tell me, as I've said before, the patient is complaining, or I see side effects from the injection you gave earlier. Document immediately after. Take credit for your teaching. What signs and symptoms should the patient report to me this evening when they get home? You don't have to call me if it's slightly sore or if you run a slight fever. And any adverse effects, of course, have to be reported so they can put in the patient's chart that they perhaps have an allergy or reaction to that medicine. Many patients give self-injections, especially of insulin, and this is something super common. And of course, your patients will need to teach back to you, demonstrate back to you, and if they're giving it to a family member, do you have someone that can support you? Do you have someone at home who can give you your testosterone shot or your B12 injection or your iron injection? Making sure that we're teaching the support personnel as well as the person who is getting the medication, okay? The age-related things that go along with the geriatrics, of course, are the lack of muscle mass, the lack of perhaps they don't want to tell you that they're having this little reaction. They don't want to bother you. You can also put a little bit of a numbing agent on them, especially if they have dementia or if they're fearful from the injection. There might be people who are fearful. And I always tell you guys that if the patient says, is it going to hurt? I'm always honest and I say, you know, it will sting a bit. It's a needle. I will be as efficient as I can if you can relax, and it will go much better, if you're in a relaxed position. Okay. Now, again, this is another unit here, so I would stop you until we get to this unit. We will be at this unit around week 13, and intravenous medicines will be at about minute 35 on this PowerPoint. So just write that down if you want to go back over it. Minute 35, we're starting with intravenous medications. They go into a vein, directly into a vein, very quick absorption, of course. IV push medications are out of the scope of your practice, but you can set up medications by a pump. A bolus the word bolus means giving a concentrated dose quickly. Okay, we might call a bolus giving someone fluids when they're dehydrated. That just means giving a lot in a quick amount of time, and to see how the patient tolerates having that much fluid, and how does their heart and kidneys work with that. If it's a really hard medication on the veins, we don't do boluses very often, and we usually will do them at a specific rate as ordered. Okay, you guys will have to learn how to calculate mils per hour and drops per minute of IV medication, because very often in the urgent care clinics there's no pump. If you are giving medications, it's often by a bolus, and this is a skill that you will need to have. To reduce harm, of course, don't be mixing in a bag if you don't have to. Don't push medications too quickly, which again is out of your scope. You may be monitoring the patient after the RN has done an IV push medication, so you should know what medication he or she has pushed so that you will know what to watch for. And the changes happen here in minutes instead of hours, because again it's going right into the bloodstream of the patient. So we have to make sure that we're watching for quick changes to happen related to the therapy. This cannot be delegated. Again, your patient or your NAP may come to you, or you may say, I need more frequent vital signs, or they may come and say their IV is leaking, or their bed is wet, or I see blood on the dressing. Those kind of things can be reported to you, and the assessment then is done by the nurse. As normal, we immediately after giving the bolus or the IV medication chart it, and how the patient tolerated it, and any teaching we did, and of course whatever we have reported to the provider if there is a reaction of any type. There are all different types of IV needles as well, and catheters that we put into the body. You guys will learn in semester 3 how to insert the catheter. In semester 1, we will learn how to maintain the IV tubing, the IV site, all of the connections, and the drip rates as it relates to IV therapy. There are many reasons for IV therapy and purposes for IV therapy. A few of them that I want you to know, of course, would be nutrition, blood, medication, electrolytes, fluids for hydration, right? Those are the main reasons why intravenous therapy is chosen. Also, perhaps trauma, emergency, or urgency is why we would choose IV therapy over a different type of therapy. Okay. Next, remember our patients who are geriatric might have CHF. They might have renal impairment. They might have kidneys that don't work as well as they, of course, did. They have to be able, they being the kidneys, have to be able to receive that amount of fluid and eliminate the toxins, and after the liver has broken them down. So very cautiously do we give boluses of 500 to 1,000 mils to an elderly person who has heart failure and edema. Where is all that fluid going to go when the heart that has failure and does not work efficiently, where is that fluid going to go? So very judiciously giving fluids to that patient population and watching them very carefully, especially for crackles. Crackles being the first sign that they are taking on fluid that they cannot circulate. Okay? We're going to do piggybacks. We're going to do primary tubings, and we're going to teach you how to use those tubings so that you can go to the clinic and perhaps help the nurse when you're in your preceptorship with maintaining an IV drip. Okay? We do have some pumps, and you'll do that in semester 3 in SIM. But what I want you to know here is that we use needleless, safe systems when we are putting, let's say, a tubing together with a port. It's usually all needleless and aseptic, and we very carefully will follow along aseptic technique in those cases. We don't have our nurse-assisted personnel give the medication, but oftentimes they will come and tell us, of course, the pump is beeping. Again, there's moisture or blood around the insertion site, or do our frequent vital signs for us and alert us to problems that they might see with the therapy. Okay, document as always. Very important here to make sure you have I&O going, that you are monitoring their intake, hoping that we have output that matches that in a healthy kidney, and hoping we don't see signs of overload in our older patients or compromised patients. And in dehydration, for example, the urine should begin to clear. There should be a higher volume of urine. The patient should become less tachycardic. Mucous membranes should start to moisten. Skin turgor should improve, right? These are all goals and outcomes of that therapy that we would look for to tell us that what we are doing is working, my evaluative measures. Okay? When I go into the room, I always like to explain to the patient what I'm giving them. This is your Rocephin. It is for your osteomyelitis. You'll be on this for another week, right? Just explaining what you're giving, especially when you bring something new in, or you've just been into the room and you're bringing a different bag than the last bag. You know, what is this bag for now? Why is this bag look different than the other bag? And we tend to not stop and talk to our patients like we should about our therapies. Geriatric patients can become toxic, especially from very strong antibiotics and fluid overloaded. I've already talked about both of those points, and in that older geriatric population, that's the most important thing, as well as, you know, any kind of an allergic or anaphylaxis reaction. We're also going to start teaching you about, and in the unit on IV, you will need to be able to define phlebitis, infiltration, and extravasation. I will hand you out handouts on how to assess infiltration, phlebitis, and we will also really be watching, I'll really be teaching those points because you'll be tested on those, as well as really your responsibility if you're, you know, the RN is pushing the medicine and then you note that they have a phlebitis. Of course, your job to alert that. So write down phlebitis and infiltration. It's in your book. There's several tables. And that week in your 122 module, you'll also have the handouts on how to assess for infiltration and phlebitis. And we'll go over it in class extensively so that you know how to assess for that. Okay? Many people have little sub-Q buttons. This is kind of a very large picture of some of these pumps that we have, like insulin pumps that go underneath the skin, and the little button that we can feel underneath the skin. So truth of the matter is, these days, especially our younger population who have type 1 diabetes, we try to go to a pump if possible, because the pump has a sensor on it and it senses the blood sugar just like sort of your pancreas does, and it can give insulin, and the patient can read it. They can read, see the little sub-Q button you see there in the front is under the skin, but the pump is on the outside, so the patient can program it, give more, give less, and bolus themselves with some insulin. Let's say their blood sugar is high. And so this is really the wave of the future. This is really helping our uncontrolled type 1 diabetics to have more of a lifestyle that is controlled, and they can control their disease better. But we won't teach these in the lab. Okay? And I'm not going to teach you which kind of needles go with those because you don't learn this in the lab. But I think it's just good to have that little bit of information about those subcutaneous